Good evening, ladies and gentlemen, and dear colleagues. This is Jubail Islam, medical physicist of Leavitt Cancer Hospital and Super Specialty Center, Dhaka, Bangladesh. And currently, I am serving as Secretary of Bangladesh Medical Physics Society. I wish all of my colleagues around the world a happy International Medical Physics Week. I am pleased to welcome you to our third webinar session on the occasion of International Medical Physics Week 2023. We are also very pleased to announce that already 350 participants registered for this program from 40 countries. And today's program will be moderated by Mr. Kamanzi. He is from Rwanda. And now floor is Mr. Kamanzi here.
Thank you so much, Mr. Jubail. I am Kamanzi, a medical physicist at Rwanda Cancer Center. I completed my postgraduate studies in medical physics from Bangladesh, 2019-2021. Therefore, I am a Bangladeshi Medical Physics Society member. Today's topics presenter is Masud Rana. Masud Rana is a senior medical physicist at Gaborone Private Hospital in Botswana. In the Department of Oncology, he has 12 years of experience in radiation oncology as a medical physicist. He holds MC in medical physics and biomedical engineering with a specialization in radiation oncology physics. Throughout his career, Masud Rana has worked on various organizations related to radiation oncology physics, collaborating with radiation oncologists and health professionals to achieve successful outcomes in cancer treatment management. Last year, he joined the hospital in a country named Botswana, which is located in the southern part of Africa, to implement VMAT-IMRT radiotherapy treatment modalities and actively participate in the image-guided brachytherapy for cervical cancer, which is the first kind treatment in Botswana. He is passionate about learning new updated knowledge about medical physics and has always been active in various scientific activities and enjoys sharing among other field of colleagues in medical physics professionals. He was former coordinator science committee in Bangladesh Medical Physics Society. And Masud Rana is excited to participate in International Medical Physics Week 2023, where he looks forward to sharing his knowledge and insights with the fellow physicists in the field. So from now onwards, we should hand over the floor to the presenter for delivering his lecture. Thank you.
Thank you, Kamanji. Dear colleagues, good afternoon from Botswana. And I'm just going to share my screen first.
Excuse me, sir. I forgot to mention that while Masud is sharing his screen, audience, during presentation, you are invited to write your question in chat box. And after presentation, there will be a session of questions and answers. Thank you.
Yeah, thank you so much. Is my screen is now visible?
Yes, we can see a Zoom, but we don't see at the presentation, sir.
Please first open PPT, then we'll share from the share screen.
Is it visible?
No.
Not yet.
I don't know.
At first, open your PowerPoint. Don't share. Don't select show at first. Then you
That's fine.
share from this share screen in your PPT. Then you will select show option all.
Is it visible now?
Yes, yes, it's okay. High precision radiotherapy advantage overview traditional radiation therapy. This slide is visible.
Okay. Okay, sorry for the inconvenience. Good afternoon from Botswana. So this is KM Masud, Rana, senior medical physicist. I'm working in life Gaborone private hospital in Botswana. So today my topic is about plan evaluation in high precision radiotherapy. And I am welcoming all of my colleagues and wishing International Medical Physics Week. And I congratulate Bangladesh Medical Physics Society to initiate such kind of academic activities, and they are doing it in continuous mode. So it is really appreciating, and we can share our knowledge among us, which is really needed in this medical physics. So let us go with the first slide. So what is the definition of high precision radiotherapy? So high precision radiotherapy actually by reducing the technical and clinical uncertainties with the help of advanced imaging techniques and technical features. So let's say such as CT scan, MRI, PET-CT, as well as CBCT to map the tumor and surrounding healthy organs more accurately. And it is possible to effectively destroy the tumor with high dose while minimizing the risk of damage to surrounding healthy tissue and organs. This is the definition and of high precision radiotherapy. And there are so many high precision radiotherapy techniques is coming up. Some of them are still on research. Let's say the hypofractionated radiotherapy plan. So we will see a lot in future. So this is the high time to get oriented and get ourselves be ready for those high precision radiotherapy, which will be coming up soon. So what kind of high precision radiotherapy in this radiation oncology? There are various kind of high precision we can divide. Let's say 4 kind of high precision radiotherapy, which is one is IMRT. This IMRT actually uses advanced software and hardware to shape radiation beams to fit to the contour of the tumor, and which allow the high dose of radiation to be delivered to the tumor, while we are minimizing the exposure to the surrounding healthy tissues. At the same time, in VMAT, this is also a form of intensity modulated radiation therapy, but only the difference is for this technique, the gantry is moving and rotating around the patient, and it also using multiple angles continuously and modulating the intensity of the beam as well as the dose rate during the treatment. So this is a bit advanced and quick treatment modality than IMRT, we can say again. And the third one is a stereotactic radiosurgery. So as we all know, the SRS is a very high dose phenomena of radiation. And basically, those kind of SRS actually happening in the brain tumors, which those tumors is very difficult to reach by the surgeons, neurosurgeons. So those kind of patient is sent to radiation department for the radiosurgery. And another technique of radiosurgery, like stereotactic ablative radiotherapy, which is similar to SRS, but it delivers high dose of radiation to the well-defined tumors over multiple sessions. And this can be used for lung, liver, and any other part of the body. Those areas, these are the areas actually we can divide the high precision radiotherapy like that. Now, if we concentrate or about the advantages over the traditional radiotherapy, so we can easily say that a high precision and advanced radiotherapy actually the shorter treatment times, and it has fewer side effects, and it improved the outcome by controlling the TCP and NTCP for certain types of cancer. So if I quote a diagram from a research article, you can see there's a two diagram here. One is A and one is B. You can easily understand there is a two line graph here. The right side graph is noted as a tumor control graph, and the left side graph is named as a normal tissue complication graph. And most of us, we know about this graph. So this graph actually indicates the TCP and NTCP. And what we know actually, this graph in between, there is a separation. So modern radiation is actually making the gap is better, the separation is bigger. So then the outcome of the objective of the radiation will be betterly reached. We can get the better objective for by radiation. So we can control the tumor better way, and we can control the complication of the normal tissue also in better way. So if you see the figure A, so you can see that there's a therapeutic window. It is a bit narrow than the second one, B. So here it demonstrates the suboptimal therapeutic ratio, whereas the other one, figure B, it is optimally therapeutic ratio is achieved when this two graph is maximally separated. And what are the factors actually made this happen? And that is the new advanced modalities of the radiation. There are so many radiation inducer. There are many radiation indicators are available in the radiation oncology, which can increase this separation. And that is the reason this era, the radiation therapy is going towards the high precision radiotherapy, because you can control the tumor more, and at the same time you can also control the normal tissue complication, which is expected. So we can treat the cancer as well as we can spare the tumor. So this is the reason we should cope up with the new high precision treatment modalities in radiation therapy. But there is a reason, there is a condition we have to fulfill before we start this kind of high precision, that it requires a specialized equipment and high skilled radiation oncologist, medical physicist, dosimetrist, and radiation therapy technology. So it may not be available at all the cancer centers. So we need to fulfill those requirements before starting this high precision radiotherapy. So what is the importance that today the topic is plan evaluation in high precision radiotherapy. So we need to know what is the importance, why it is important. So in a radiation high precision plan, the complexity of a radiation plan is actually directly related to the technical challenges involved to achieving the desired dose distribution. So when we see in a treatment planning system, the distribution, dose distribution, so it involves a complex plan. Most of the time it may involve, and those complex plan actually involves with radiation beams, precise beam angles, and sophisticated radiation delivery technique like IMRT and VMAT. So the complexity, we need to make sure the more the plan will be complex, we need to make sure the deliverability and to reproduce that complex technical things in real patient when the patient is getting treatment. So that is the reason it named as a technical challenges. So when we are making a treatment plan, we have to ensure, we have to find out the complexity and whether that complexity we can achieve. If it is achievable, then we can go for the treatment. Then another thing is like radiotherapy plan should be indicate its clinical suitability and deliverability. A patient, we need to assess the patient first, whether the plan we are doing, this plan would be the suitable for that specific patient or not. Number one, that is called clinical suitability for the patient. And another is deliverability with the patient. Like if the patient is not coping up with that arrangement, what we made for that patient, let's say a brain patient, we want to irradiate the brain tumor very nicely with planning a non-coplanar arrangement, let's say about 2 non-coplan and another 3 coplan. So it is about 5 arc. And the patient is not able to lie down on the couch about let's say more than 15 minutes. And if we want to finish that treatment for that particular patient, so that patient may not be able to lay down on the couch more than 15 minutes. But if we want that complex arrangement treatment plan for that particular patient, that requires the time around about 25 minutes. So we need to assess that suitability in the and deliverability for the particular patient. So that is very important. So that comes under that plan evaluation for patient specific. And again, we need to as we all know, for any VMAT and IMRT plan, we do QA before implement the radiation on the first day. So sometimes many machines is the TPS can show that this plan is possible, but and the real when you go for the QA, you will see there are some machine may not be able to deliver some of the segment because you are very tight on some of the OARs, or maybe you are very tight on the normal dose tissue spread. So the TPS created a lot of small segments in the plan, and that segment that Linux cannot may not be able to create that segment. So Linux will create an interlock and it will appear as a segment error. I have experienced with this kind of segment error in my experience about many times, about 2-3 plan we saw the before when we started doing that QA, patient specific QA, it is machine says it is not deliverable. So then we go back to the TPS and we found out the plan was too tight for the OARs. So it has created a small segments, and that segments the Linux is not able to produce. So that is the reason it comes under the suitability and deliverability. So we need to assess this one also. for a radiotherapy high precision plan. And in order to high dose to the target, minimum dose to the critical structure, and accurate delivery of the treatment, we have to make sure those plan evaluation criteria, whether it is fulfilled or not. Then, in modern three-dimensional patient data allow us, actually, we know that most of the time we are familiar with TPS, DVH. In DVH, we can see the dose statistics for the target OARs. But one thing is, as we all know, the major drawbacks of a DVH, it does not provide the data regarding the spatial information like identification of the hotspot and the cold spot or the location. So this if you see this, you can identify the volume 95% is getting 70 gray, let's say, and another volume is 30% is getting 10 gray dose. So you can understand the dose volume ratio. But if you want to understand that where is the Dmax in the patient body or even the target, you can't. This DVH can't help us. So we need to assess some of the things in the plan TPS, which is bit unique and which is recommended to check. And as we all know, if there is any plan, the hottest spot is outside, let's say outside the PTB, it is not recommended. Hot spot should be inside the PTB, and the cold spot should be also, we need to make sure that there will be no cold spot inside the PTB. Hot spot can be inside the PTB, but cold spot cannot be inside the PTB. As well as we need to understand, we need to make sure that where is the location of the hot spot. If a patient tumor is just adjacent with a brainstem, so that hotspot should not be near the territory of the brainstem. So if we found the hotspot, let's say 105 or 107% hotspot near that dose cloud near the brainstem or target, then we have to shift that hot spot from that location to any other place, which is a bit away from the brainstem, because we all know that brainstem is a serial organ. So we have to be very careful for the serial organs. Even nowadays, the serial organs also, there are some recommendation like we should think about the volume of those serial organ, how much it is getting in volume-based analysis. So therefore, we require other objective parameters such as homogeneity index, conformity index, gradient index, and slice by slice visual review of dose distribution for the high precision radiotherapy plan. So before starting a high precision radiotherapy plan, we need to consider some of the things I just want to share. So where we are, we need to check the plan evaluation after these things when we checked out. Let's say we need to check patient-specific parameters like patient tumor location and patient tumor size and shape. For the dose prescription, the target volume, prescribed dose, and fractionation schedule. For the treatment planning system, there are some settings, as we all know, that dose calculation algorithm and grid size, like calculation properties, and another thing is IMRT properties, and the other things. And beam geometry, like how many arc, how many number of arc you are choosing, and where is the location of the isocenter. And here, I would like to share some of the information about arc. So there is a recommendation, as we are using Electra, like there is some recommendation from the Electra, like if you have a solid tumor, like the tumor is a regular shape, like let's say a brain tumor, or let's say a small prostate tumor. So we can use one arc, even in one arc, we can give two arc. So beam can be one and arc can be two. But if we can achieve by 1 arc the required dose distribution and the OAR tolerance, then it is better to use 1 arc than 2 arc, because we need to think about the machine as well. So when we are using 2 arc and when we are using 1 arc, so if the coverage and OA are having no significant difference, then 1 arc is better, because patient time on couch will be less, definitely, when we are using 1 arc. And when patient time on couch will be less, the other uncertainty related to the setup, patient inconvenience, everything will be improved. This is the number 1 for the patient. In terms of LINAC, if we consider the LINAC, as you all know that the LINAC is also having some mechanism to produce the radiation. So they are producing radiation through target, and that target assembly, there are some modulator, the magnetron, klystron, lots of things are associated of this radiation. So if we reduce the monitor unit, then it is also, we are increasing the lifetime of a machine. So maybe that is not visible, but in a long run, if you count that maybe in one a magnetron having a lifetime, let's say 3 years, maybe you can increase the lifetime by 1 year, and it will be a good help for the hospital also, something like that. So we can also consider those things. If it is needed, only we can apply those things, and if it is not needed, then we can skip and try with 1 arc. And the planning objective also, we need to check what is the target volume, objective, dose constant, and critical structure associated with that. If there is any overlapping or not, if the target having 2 or 3 dose level, or maybe sometimes we get SIB plan, like a plan we will treat with 25 fraction, but one volume will get, let's say 50 gray, another volume will get 55 or 56 gray. So we need to make sure those things before starting a radiotherapy plan. And then only, because when we start the plan evaluation, that is already those things is done. So before plan evaluation, before starting a plan, if we check those things, so when we will go for plan evaluation, that will be easier for us. We may not be go back to those things to check, or maybe we will skip some errors also. So what is the type of evaluation? There are 2 categories of radiotherapy plan evaluation can be assessed. And the number 1 is qualitative evaluation. So this qualitative evaluation actually involves evaluating various aspects of plan subjectively based on the clinical expertise and judgment to assess the quality and appropriateness of the plan for a particular patient. So you can see there's a photo in the right side. There are so many vegetables here. I'm just correlating this qualitative evaluation in our daily life. So everyone, we go for buying this kind of vegetables in the market, right? So when we go to the market, then what we used to do, we used to find out, we also do something qualitative evaluation by seeing visibly whether the color is nice, the looking is fresh, or the smell is nice. Yeah, so it looks fresh. So all of them, even the quantity, the individual quantity is also better. It is not that thin. It is good to eat. Those things actually comes under the qualitative evaluation. And there are common aspects in a radiation plan. What we already have some information, like we saw the target coverage, which is whether it is compliance with the prescription or not, whether the dose distribution is compliance with the prescription concept or hotspot concept or not, normal tissue sparing is fulfill the tolerance criteria or not, and the feasibility of the treatment delivery compliance with the patient setup uncertainty or not. So those things will come under the qualitative evaluation. But if we go to the quantitative evaluation, let's say it involves the objectives and quantitative measures to evaluate various dosimetric parameters and characteristics of the plan. So we actually, there are some common aspects, and you can see there is a picture here. The picture actually, why I mentioned this picture, if we go in a shop, then if there are other shops around also, but we find definitely we found some shop is many customers, they are using, they are buying from them because they are selling quality things. So that is actually why they are buying, because they found something like, let's say the vegetables they are selling, that is the quantities they are giving more, and their quantity is giving more but less price. Maybe the quality, the lifetime of those vegetables is higher than other one. So those things is assessed by that some quantitative and quality objective measures. So that evaluation comes under the quantitative evaluation. And there are some common aspects in radiotherapy plan. Let's say target coverage. The target coverage is something like volume receiving at least 95% or 100% of the prescribed dose, like 95% volume or 100% volume. We will analyze those things. The minimum dose received by the target volume, we will analyze this information. Maximum dose received by the target volume also come under these quantitative measures. Then dose homogeneity is a measure of uniformity of the dose distribution within the target volume. And dose conformity index, this evaluates how well prescribed dose conforms to the shape and size of the target volume while sparing surrounding healthy tissue, which is called as a conformity index. So, and normal tissue sparing, it involves assessing normal tissue and critical structures, and plan robustness, plan setup, everything is nice, patient specific QA, internal organ motion, those things we can quantify. So this comes under the quantitative evaluation. And the plan comparison, you see, sometimes we used to do 1, 2, 3 plan for a specific patient to understand which plan is betterly meeting the clinical goals and least amount of dose to the healthy tissues, as well as it needed less MUs, it needed less delivery times. So all of them will become under this plan comparison, and we can do that. We can assess those things in the quantitative evaluation. So recently I have come across a plan evaluation index, which is published by a famous doctor in India. So he actually provided an index which is called the COSIT index. So it is very easy to remember, because we all suffered for the COVID. So instead of COVID, we can just remember it as a COSIT. Just V is replacing by S. So it is very easy to remember. So in that way, the doctor found out this index, and I like to share with all of you, and with some of the additional information as well about this index. So one is coverage index, O for OAR index, S for spillage index, I for imaging index, and D for delivery index. So what is the coverage index? The coverage index is something like a radiotherapy plan according to the RTOG guideline is considered to have good coverage if it is more than 90% of the prescription isodose is cover 100% of the target. So it is considered as a good coverage. But when the plan is less than in between 80 to 90% of the prescription isodose covers 100% of the target volume, then it comes as a minor deviation. Sometimes, so some of the cases we accept this kind of plan, because let's say a plan the target is very much adjacent with the where, like let's say eye or optic nerve or brain stem or even lung, even heart. So those kind of situation, the doctor sometimes accepted this minor deviation because they want to treat the tumor as well as they want to spare the functionality of the OARs. And the major deviation is straightforward. When it is 80% is less than 80% is covered 100%. So it is a major deviation. So we need to review the plan and find out a reasonable solution to make it at least the minor deviation category. And in a coverage index, the GTV 90% prescription should cover the 100% volume. D95 minimum dose delivered 95% of the PTV. D98 minimum dose delivered to the 98% of the PTV. We need to report those information. And D50 is like minimum dose delivered to the 50% of the PTV as referred is at median dose. As we know, the ICRU 83 now is mentioning this median dose. They're raising that median dose we need to report because it also giving the impression of uniformity of a plan. And D2 is the minimum dose delivered, and Dmax maximum dose delivered to the PTV. So this information comes under coverage index. Then OAR index, if we see for a functional point of view, body organs has conceptually divided into that serial and parallel. So what are the serial organs and why it is called as a serial? Because in serial organs, actually, there are some functionality we must guarantee to preserve. They have some tolerance doses. So if we exceed those doses, then the functionality of those organs will get damaged. So let's say spinal cord, brain stem, optical nerve. So those things comes under serial organs, and we have to we have to see the maximum dose to that organs, and that is the best predictor of loss of function. If we are able to achieve less than that maximum dose, then we can say the serial organs will be spared. Now, the parallel organs like lung, liver, parotid. So we need to have a volume assessment for those kind of parallel organ. And for that, it is very much needed for a complete organ delineation is required. So mean dose is the indicator for this predictor for the loss of function for parallel organs. And for example, for a parotid case, to protect the xerostomia, we need to make sure that the parotid should not be exceeding the mean dose more than 26 gray. And there another is mixed serial and parallel organs. Kidney is a serial and parallel. So when we put any objective for the kidney, we need to see the maximum dose, as well as for the kidney, we need to see the volume assessment, like we need to see the mean dose as recommended in RTOG. So now it is a spillage index, as we know, the conformity index, homogeneity index, gradient index. Those index actually give you an impression about a plan, whether it is having a spillage is fulfilled or not. Let's say there's a conformity index equation, as you all know. We created a Excel sheet like that with that equation, and the equation is Patrick CI conformity index, which is more popular, and target volume covered by the prescription isodose. Let's say 50 gray prescription. So put this value in target or PTV and note that value in the PTV statistics, like in DVH statistics. And TV is the target volume. Note that volume of the target CC from the structure tab. And PIV is the prescription isodose. If our prescription is 50 gray, so we can create a structure and get the volume of that 50 gray. Ideally, conformity should be 1, but it is not at all possible. It is ideal thing. So ideal is a bit far from the practical situation. So most of the time in Monaco, we will be happy when the conformity index more than 0.7 or in between 0.7 to 8. So we get a good plan when the conformity index in between 0.7 to 0.8 in the dose statistics. And another thing is the homogeneity index. You can create an Excel sheet like that. The equation HI homogeneity index is the Imax is the maximum dose in the target, and RI is the reference isodose. If the dose is 50 gray, then you have to put that value and maximum. So it should be less than less than or 2 is the considered as a normal value. And gradient index is again Patrick given a gradient index formula, which is V50 by V100. So V50 is volume receiving 50% of the prescription dose, and V100 is volume receiving 100% of the prescription dose. So we can go to the prescription tab bar and put that value and create a structure and get that volume from this structure bar. And likewise, we can create a Excel sheet and analyze. And a perfect plan will have a Patrick GI that approaches 1 is a perfect plan. Like it should if it approaches 1, ideally it's not possible, but most of the time we used to get 1.2 to 1.4, something like that. Then imaging index, I think the time is a bit running short, so I'm a bit fast now. Imaging index is we need to analyze the plan slice by slice. So in the view of like where is the cold spot, where is the hot spot, to find out the location and whether it is still clinically significant or not. If it is not clinically significant, then we can go ahead. Those things actually give this information, this axial view, sagittal view, coronal view, slice by slice. We can get information, and if it is we are happy, then we can tick it is imaging index is fine. Then delivery index, complexity of the plan and delivery. Already we have discussed that a more complex plan has more beamlets segments, so whose beam aperture are mostly irregular and mostly irregular. So it leads that so more smaller beamlets and segment, overall treatment accuracy it leads. So we need to try with less beamlet and segment to make a plan as our objective or desire. And if we can achieve that, then we should not go with the more segment and more beamlets. The number 2 is monitor unit evaluation. As you know, if a plan, we can achieve with a co-plan, no need to go for non-co-plan, because if we go for non-co-plan, then we are making the arrangement complicated, and making the arrangement complicated means we are introducing more uncertainty. And so it is not recommended to introduce more uncertainty of the delivery technique if it is not required. So we can evaluate like that: plan 1, plan 2. If the plan 1 is 537, you can see the plan 2 is 592. To the modulation factor is 2.7 and 2.3. So if the modulation factor, which is 3, and if the modulation factor is 2.7, but the clinical objective, let's say PTV and OAR, is not that significant, then we should go with 2.7 modulation factor. So I'm just going through a workflow of the high precision radiotherapy, a quick one, quickly. So before starting a plan, we will see all the OAR targets, OARs like this. We will see. Then we will check the prescription and fractionation schedule. We will check the beam parameters. We check the energy. We will check the treatment units, delivery techniques. Then we'll check the beam geometry. How about the arc, the gantry angle? Even you can see the clockwise or counterclockwise, those things. And we will check the couch is marked or not. if we use bolus, whether the bolus is included or not. So those things, then we need to check the calculation properties. The grid space should be 0.3. But if it is SRS, there are some recommendation we can go to 0.2. But provided you need to make sure if we go to the grid spacing less than 0.3, it affects the calculation time. So you have to be very careful with the grid spacing. It is a by default 0.3, but and the dose deposition to them, it should be medium, and the algorithm settings, you can see the per calculation should be 1%. You can make it 2%, 3%, but we used to do it 1%. And the sequencing parameter, you can see number of R2, number of control points, minimum segment width, fluence smoothing, then IMPW prescription parameter. We'll check all of them. If there is any surface margin is required, we need to check whether the surface margin is good enough for us or not. Then 95% coverage. This is the 95% coverage. It is 100% achieving our requirement. And this is for 75%. We will see how the dose gradient is happening for this plan. And this is the 50%, and this is the 25%. So those information we will see. Even this lower dose spread also is guide us whether our target, like target oriented beam arrangement is there or not, whether we maybe let's say by mistake we use a couch 90 degree. So when you check the lower dose spillage, it will give you that information, that unwanted kind of dose distribution. So that will give you to check the couch, whether the couch is 0 or 90, because it should not be like the dose should go up or spread a large scale. So those things is an advantage for the low dose spread. Then this one, when we are done with those things, then we need to check where is the hot spot. Though in the lower bottom of that isodose, we will give that value, let's say 105% of this plan. So we put it that 105%, and we tried to find out where is the location, and we saw there is no maximum dose cloud inside or outside.
Excuse me, sir.
Yes.
Excuse me, sir. We are running out of time. I think you need to rush so that we can.
Yes.
So
this is the dose statistics. I'm just about within 5 minutes I'll be done. So also there is a way you can see the patient orientation, like when you treat the patient, how that delivery will be. There is a option in Monaco in view room view display, so you can see and you can understand whether the arrangement is nice for this patient delivery or not. And lastly, this is my last slide. I just want to share ensuring a standard of quality of for high precision radiotherapy. We need to prioritize the patient safety and treatment effectiveness through proper quality control and adherence to established protocols. And it is also essential to work with closely the multidisciplinary team, which is, we all know, radiation oncologists, medical physicists, dosimetrists, and radiation therapists. We have to work together and develop. Even we have to participate in the review of the treatment plans, monitor treatment progress, evaluate the outcomes. We have to share each other. Then only we get to know what kind of thing we need to change our existing way. And the regular quality assurance checks, including the machine calibration, quality control tests, those are the things will actually minimize the risk of error. And it is also crucial to stay to update the latest technological advancement in radiotherapy and incorporate the evidence-based guideline into the treatment planning to optimize patient outcome. So today, the way we are doing the treatment planning, maybe after 1 or 2 months, even a year, that there will be new approach will come. So we have to be updated with those information and get into with that line. So by maintaining a diligent standard of quality in high precision radiotherapy treatment planning, we can ensure the patient receiving safe and effective treatment that maximize the goal of radiotherapy. I'm just sharing a good book reference, which is called Strategies for Radiation Treatment Planning. So you guys can collect this. I think this having a very good information about strategies, so you can get into it. And thank you very much. I'd like to express my gratitude to everyone for your time and attention during my presentation. So I hope you found some information is helpful and relevant to your needs. Thank you.
Thank you so much, Masud and Rana for nice presentation. Before moving to question session, and we have a small announcement to the audience. I would like to invite you to fill the evaluation form, which was sent to your email for your certificates after this session. And now, from now onwards, I'm going to questions. We have a list of questions from participants. The first question is from Masud Mokres Mandal. He said, for soft tissue treatments using fiducial markers, a CT scan can be obtained.
Yes, we need that one, and it will help us for a good setup information, and you will get a less shift for those kind of. So fiducial marker is always good for obtaining a planning isocenter from the reference of CT.
Thank you so much. The next question is from Paspen. As you said, you got some segmentation error. Could you please tell me the approximate segment size and which linac you are using, as well as the Monaco version?
Yeah, thank you so much. It is a very good question. Actually, if you use a lot of control points and your width of the beam width is very less, let's say 0.5. So the system, the optimizer will try to create some segment for the planning. So which it may not be able to reach by the machine. Machine cannot be able to create that small segment. So what we found out, I experienced with a SRS plan, and we used the segment size about 0.5 that width, and it complained about that segment. It was let's say the tumor having just adjacent with the brainstem, and it was trying to spare the brainstem, and in that area it has created lots of small segment in those gantry angles, and the machine was not able to produce that segment size, and it was complaining segment error. So it is always better to put that with 2. I think I showed this presentation about that segment, where to put that value. I think you will get that information in the calculation properties.
Okay, thank you. Actually, the next question is from me in my side. Usually for SIB plans, from my clinic, in most cases, you find that PTV, there is an overlap between PTVs and PTV and OIR. For example, we have PTV 70, PTV 50, and PTV 45.
Yes.
At the end of the day, you realize that PTV 70 is overlapping with PTV 45. And
yes,
sometimes PTV 70 is overlapping, for example, DECTAM. So
yes,
in this kind of scenario, what do you recommend as a planner to start with?
The main thing is for SIB plan, so margin concept we need to maintain for this PTV 45, 50, and 70. Let's say PTV 45 and 50, if you create a PTV 45 95% dose coverage, as well as then 50% PTV 50 95% coverage, it is achievable. But if the PTV 70 and 50, the margin between PTV 50 and 70 is very less, let's say 0.5. and you want that 0.50 PTV 50 to PTV 70 within a short distance, 5 millimeter, which is not possible in practically. As we all know, with the physics, the gradient is always like 3 millimeter. It can make a gradient about 7 to 10% dose. So if you want within a 5 millimeter about 30% dose, so which is not possible, but which machine can try, at the end of the day, you will lose coverage in other PTVs. And come to that OAR overlaps. If any OAR is overlap with any PTVs, we should not take those overlaps as a OARs. We can, in Monaco, there are some way you can create a shrink margin, but most of the time, the shrink margin sometimes is not successful in some PTVs. Let's say the margin is very less, then it may not be successful in that way. So what I do, I always subtract the volume which is overlap with the PTV, and named as a PTV optimization, which optimization is not included with the OARs. So this is another one way. Another way, if you are not worried about the overlapping structure, we will get 70 gray dose. So then you can go with those overlap as a PTV. So it is still a clinical choice, clinical call. If the doctor is happy with that overlap structure to be considered as a PTV and giving that dose like 95% of 70 gray, so we don't have any problem. But you can do that. But if the doctor is telling the overlapping structure we can skip in the optimization, then you need to create a structure subtracting the overlapping structure of OAR and use that structure as a optimization.
Thank you, sir. The next question is from Push Pludge. She said, which is better for dose delivery, using one arc of desired dose or multiple arcs of raw dose, and getting the desired dose on an intersection on the target center, keeping the dose versus deep variation into account?
As I explained in the lecture, that we can use one arc, one beam, two arc, and we can use two beam, one arc, one arc. Elector having a facility like, if you use one arc, let's say a cervix patient tumor volume, and it has this, the nodal involvement as well. So you will find that the target is very complex shape. So when you have a complex shape of tumor and you are using one arc, that may not be optimal to create a nice distribution as expected. So it is in that situation, we need to use multiple arc. And if you use one arc, one beam, two arc in the calculation sequencing parameter 2 arc, there is a benefit, as Electra says. So the target will divide it by the system two part. One part will take care by the number one arc. So the segmentation, like the segment of the MLC will be regular, very regular. So it can reproduce in the treatment delivery, and your QA will be QA pass rate will be very high. Like very high in a sense, it will be like 2-3% more. If you use one arc, and if you use two arc, you will have a more QA passing rate, because the regularity of the segment is nicer than when you are using one arc. So I think you can just go through that physics notes for that Electra training books. They mentioned clearly that if you use one arc, one beam, two arc, that will be betterly benefited for this kind of complex plan.
Okay, sir, Mr. Yan, I don't know, he said, is homogeneity index an important aspect nowadays?
What is that?
This is from Fu Yan Ding.
Yeah. So homogeneity index actually, what it is meaning, it is the ratio of your prescription, the maximum dose, and your prescription. So now still it is a bit relaxing. You can see the ratio when the homogeneity index is 2 or less than 2, it is okay. So it has a room. So room is like, if the doctor is asking, I want the GTV maximum dose, let's say 110%, 115%, I don't have any problem. So the homogeneity index will be affected, like the ratio will be more. So in that note, homogeneity index is not a problem, because the clinician wants the maximum dose, very maximum dose in the GTV, and clinically, that is radiobiologically, they found it is more clinically patient beneficial. So in that way, homogeneity index nowadays is not that important, but you can still see what about the homogeneity index. Yes.
I try to go faster with question because we're running out of time. Next question is Rajan said, during planning, what should we prioritize first, OER, PTV coverage? I think this was answered. You can say a little bit about this one.
Which one? During planning, what should be prioritized first, OER or PTV coverage?
Yeah.
Yes. I think only thing is like, as you saw the coverage index, you have still a room for your PTV and OAR. If your OAR is a serial organ, and you can still, the clinician can accept 90% coverage, 90% prescription can cover 100% of the dose instead of 95, then you can consider OAR, prioritize, you can prioritize, because PTV always, target is always first priority, then OAR. It is a general term. You need, because we are treating cancer, we are not treating the OARs. We are treating cancer, but we are sparing the OAR. So it is always better to first fulfill the PTV and then concentrate on OAR. If keeping the PTV not affected according to our that index, we can still try to reduce, but you need to find out which OAR is your first priority. Those OARs you need to put in the layer, like first layer, second layer. In those OARs is nearby to the PTV, that is the priority. The closer the OAR, that is number one priority, then bit far than the first one, that is number two. If it is very far, those areas, no need to put even in the optimization, because those areas, there are some planners, they do, like they include all the OARs which is drawn by the doctors, and actually it is not needed. If it is the OAR is very far from the PTV, still you can calculate and get a good coverage of those. And those OAR, if you put in the optimization, also system, if it is very far, system also will not concentrate on those OARs. So keeping them in the optimization is not going to help actually. If it is far, the system will not count them as OAR.
Thank you, Sam. Mokris said, what is normal request for PTV in terms of prescription in an IMRT plan?
Sorry?
A little bit above of this, the last question.
Above the last
one question above.
What do you suggest to lower MU? Okay. So
no, sir. Sorry. It's
what is a normal request for PTV in terms of the prescription in an IMRT plan?
Oh, okay. So 95% volume is covering 95% of the PTV volume. 95% prescription, if it covers 95% of the volume of target, that is a general term. But if you ask me, for me, I always try to say 95% of the prescription should get more than 98% or 97%. It is better if it is possible. But still, there are some, they will say 95% prescription. If it covers 95% of the target, then we can accept that.
Excuse me, sir, before you leave this point, is there any difference when you say 95% of prescription to cover 95% of the volume? And second one, say 95% of the volume to be covered by 95% of prescription. Is there any difference?
No, it doesn't have any difference. It is the same.
Okay. Next question is from I think from Rajan again. No. From Amli, is in a variation in number of your MUs, what is better plan those? How has the less one and the more ones? I don't understand.
Okay, so in terms of MU, it is always recommended to make your optimum modulation factor. It is called modulation factor. It is always suggested, don't go modulation factor when it is more than 5. Keep the plan modulation factor less than 5. How we can calculate? The modulation factor you can calculate in 2 ways. Number one, so total number of monitor unit divided by your prescription per fraction dose. Let's say if your monitor unit is 500 and your prescription is 200 centigrade, then your modulation factor will be 500 divided by 200 centigrade. So it will be 2.5. And another way is you can go to the plan and see how many segment you use. Let's say if your plan is MU is 500 and your segment is 190, 195, then you can see that that is also modulation factor. These two ratio actually approximately nearby. So in either way, you can calculate the modulation factor. And how you can reduce them? You need to look into the plan and see. In Monaco, you can understand which OAR or which objective is very much affected by seeing there is a plus sign as well as there is an ISO and weighting. When you see the weighting is very much high, it is more than 10, and the plus sign is more than 3, so go to the objective and reduce them. So you then reduce them slowly, and you can see the MU will come down, but provided not to compromise the coverage of the PTV. When the coverage is affected less than 95, then stop doing that and be there. So this is what you can do that actually to reduce the MU.
Thank you. Can IMLT plan use a bolus?
Yes, you can use a bolus definitely. If let's say if a tumor is very much shallower, like it is just under the skin. Let's say a brain patient, the tumor you are not able to reach in the skin area of the brain, so you can use the bolus. But provided you have to make sure that that is counted your optimization. So if you are using bolus and you are not counting in the calculation, so it doesn't have any sense, meaning. So we need to make sure those things, because when you create bolus and calculate, the system cannot take automatically. So you have to assign the bolus.
The next question is, if calculation time is not a big deal, can the smaller grid spacing improve the dose calculation accuracy?
What is that?
That one of Paspen.
If calculation time is not big deal, can a smaller grid space? Yes. Let's say if you are put in 0.3, and now you want to 0.2. And the 0.3, the calculation time, let's say 10 minutes or 15 minutes. And when you put 0.2, it is 25 minutes or 10 minutes more. It's not a problem, but sometimes that 0.2 makes a calculation time triple times than 0.3. So that will be a problem. So you can check. It is depend on the tumor target. If the tumor target is very big, then it will be a issue with calculation time. But if the tumor is small, then you can go with a small grid size.
The next question, it comes from Arin Puzali. What is direct aperture optimization used in IMRT?
What during?
What is direct aperture optimization used in IMRT?
Okay, I didn't get that question.
Question came at 456.
Okay, what is the direct aperture optimization used in? So you are talking about maybe beam width or something like that. So if the direct aperture optimization used in IMRT, in Monaco there is a option. It is called IMRT parameters. There you can put your values. Actually, it is not recommended to tune or increase or decrease those values, because by default it will be there. Like the beam width will be 0.5, and the surface margin will be 0.3. Those are the things we usually don't touch, but we need to check them whether it is there or not. So for the IMRT parameters, we will check only the parameters are there or not, but we usually don't increase or decrease them.
Okay, the next question is from Mohammed. Is plan QA included in plan evaluation? What guidelines suggest?
Yes, plan QA always it is like when a plan evaluation is done, then still we are not ready to treat the patient. So only we are ready to treat the patient or start the treatment when the plan QA, especially VMAT and IMRT plan QA is passed. Now, this one actually there are some recommendation. Sometimes the vendor also having some recommendation. If you have a QA device, let's say, you can deliver the plan as it is with let's say it is a VMAT plan. You can during the QA you can deliver the beam gantry as it is with a arc check. Then the recommendation is like 3% dose difference and 3 mm distance. That gamma criteria, if it is passing more than 95%, then you can say it is fulfilling the criteria, and you can go for the treatment. And but there is a condition, like if any plan, it's a very large volume plan, then or let's say it is a head and neck patient, and that patient having a very large volume with nodal involvement, and as we know, the head and neck cases having some uncertainty with the patient body contour. So in that note, in the IMRT and VMAT with the head and neck is still 93, 92 you can get, and you can say it's okay. You can go with the treatment 92, 93%.
Thank you, sir. The next question comes from Dr. MD Anwalu Islam. Is there any inbuilt biological treatment plan evaluation technique like TCP and TCP in Monaco?
So far, what we are using that doesn't have any plan evaluation in terms of biological for TCP and TCP. But as we all get to know that there is a new upgrade with Monaco, which is 6 point something. So they are
6.1.
Yes. So they are trying to include some scripting which we can evaluate those TCP and NTCP. But those is like scripting, we need to get the training from Electra, how to use those scripting for evaluate a plan in terms of TCP and NTCP. But yeah, presently we don't have the present TPS, we don't have that facility. But surely Electra is coming up with some idea like that biological treatment plan evaluation.
Thank you for the good answer. Next question is from Banashri. Is doing patient-specific QA in EPID enough, or should it be compulsory to use specific detectors for patient-specific quality assurance?
Yeah, actually, in terms of it is called as a portal dosimetry. Sometimes people using initially about 10 years back, there were some centers also using it. I don't want to comment on it, but only one thing I just want to say: people always try to verify the plan QA by the machine with a third party commissioned QA device. So that will give a better confidence for the plan QA is passing or not. So sometimes the EPID, maybe the detectors, and as we know, the EPID detectors and the specific detectors having resolution is very, the difference is there. So specific detectors having more detectors, and there is a chance to miss out the spatial information if we use EPID for the patient specific QA. So that is the reason it is advised to use third-party independent QA device for the VMAT and IMRT QA.
The next question comes from Paspen. In addition to the grid spacing question, I think the smaller grid spacing increases the standard deviation in Monte Carlo. Based on which reference shall we use grid spacing of 0.3? Can you see that question?
Yes, I can see that. Yeah, it is a matter of research. I think you are right. I do agree with you on that point, that Monaco, Monte Carlo is increasing grid spacing, standard deviation. But this 0.3, it is actually the information what we get from the Electra people, like if as we are using a scan 3 mm, if we are using a CT reference that are 3 mm, we should use 3 mm grid size. If we use 1 mm CT reference for the patient simulation, then we can use 0.1 mm. So yes, the grid spacing. So the grid spacing 0.3 actually comes with that connection. They are mentioning if you are having a grid spacing 0.3, it is always advisable to simulate your CT scan patient with 3 mm slice thickness. If you want to use 0.5, then scan the CT patient 5 mm. But as we all know, if it is a high precision radiation, it is always advisable to at least 3 mm, even 2 mm or 1 mm. If you have that facility, you can go, especially the brain SRS on SRT patient. It is always advisable to simulate the patient with 1 mm or 2 mm when it is high dose radiation planning, because if you have 1 mm slice thickness, you will have the better appreciation for the fusion and find out that tumor as well as the OAR, especially when a brain patient, as we all know, getting the optic chiasma and optic nerve information, even the lens and lens information is very difficult when we are scanning more than 3 mm. So this is the thing actually. I believe this is the correlation between that.
Thank you so much for nice questions from the audience, and thank you so much for today's presenter for delivering a nice presentation. So from now onwards, I would like to hand over the floor to the organization for this event. Thank you so much.
Yeah, thank you, Kamanji.
Thank you, Mr. Kamanji, for moderating the nice program and for your valuable time. And thank you very much, Mr. K.M. Masud Rana, for your effective presentation on the subject for the plan evaluation. And we appreciate the time and effort you have put into preparing the informative session for us. And dear participants, I would like to thank you again for a successful event. And another announcement for our tomorrow's webinar. Our tomorrow's webinar will be held at the same time, 8 p.m. in Bangladesh time and 2 p.m. in GMT, and titled on establishing an image-guided SRS and SBRT program and its practice. Speakers, Mr. Shakil Jubri, Senior Radiotherapy Physicist, at Royal Marsden Hospital in London. We look forward to your active participation in our next webinar. Thank you, everyone.
Thank you.